Hello, my name is Zoya Khan, and I am an internal medicine PGY2 resident at Lakeland Regional Health. Today we're going to be talking about a very interesting case that was challenging in terms of diagnosing and ultimately the treatment that was necessary. Here we have a 45-year-old male with a history of hypertension, hyperlipidemia, a prior subdural hematoma, status post-craniotomy, as well as alcohol abuse, who presented with progressive generalized weakness, excessive somnolence, and visual disturbances. He denied any cardiac, respiratory, or gastrointestinal symptoms. On admission, laboratory tests revealed a white count of 402,000 with 77% circulating blasts, a hemoglobin of 8.6, and platelets of 42,000. His venous potassium level was critically low at 1.7, with a repeat sample that confirmed the value. As such, he was admitted to the intensive care unit. He was found to have an acute kidney injury as well, with a serum creatinine of 2.48 and concurrent metabolic alkalosis. His lactic dehydrogenase was elevated at 2386. A CT of the abdomen and pelvis showed splenomegaly. However, with that potassium of 1.7, EKG did not show any T-wave flattening or U-waves. As such, point-of-care potassium testing was obtained, which showed a true potassium of 3.0. A peripheral smear then came back that confirmed acute myelogenous leukemia, and the patient was subsequently started on induction chemotherapy with cytarabine and underwent leukapheresis. 6 hours after induction therapy, his repeat venous potassium was 5.3 and 5.8, which required intensive hyperkalemia treatment due to developing tumor lysis syndrome. So in this case, as you can see, when he first presented, he had a very high white blood cell count, which was thought to be causing continued cellular uptake of potassium by the metabolically active leukemic blasts, which is why the venous sample showed a potassium that was significantly lower than the actual potassium. The actual potassium was reflected by the point-of-care sample, which showed a potassium level of 3.0. In this case, this was very important because if we were to go based off of the potassium of 1.7, this would require aggressive potassium replacement in a patient that is already at very high risk for developing tumor lysis syndrome. In our patient, this was important because later on, after cytarabine and induction chemotherapy was initiated, he did in fact develop tumor lysis syndrome, for which he had to get urgent hyperkalemia treatment. In this case, the clinical pearls include considering spurious hypokalemia in patients with extreme leukocytosis, especially in the setting of a hematologic malignancy. Point-of-care potassium is preferred in these patients due to the immediate sample processing and reducing the risk of artifact, and avoiding reflexive potassium repletion, especially if the lab values don't correlate with the lack of clinical findings and EKG changes. And it is important to anticipate electrolyte fluctuations in patients with acute myelogenous leukemia, especially because they are at risk for tumor lysis syndrome. Therefore, cautious monitoring is essential. Thank you.